observing at the moment. I don't know, we can call today as the second wave of COVID or third wave, but we are actually observing the worsening situation which our population have predicted last year, and uncertainty of the healthcare system's capacities. We are struggling with limited number of ICUs. Everything is creating impact on mental health. I definitely want to acknowledge to the fact that it's very difficult to say like all these things are happening. These mental health, symptoms are happening because of COVID, but we can definitely say like during the pandemic, these symptoms are happening and we are observing the toll of mental health. So the objective of this particular study was to explore the impact of COVID-19 on mental health among registered Bangladeshi physicians. So registered means BMDC registered physicians, those were residing in the country during the pandemic. We did a cross-sectional study and we followed both convenience and snowball sampling recruited via social media. So it was an online survey to be more precise, and we collected data over a 3 weeks time. It happened in the initial lockdown period, 21st April 2020 to 10th May 2020. So you only have included, I already mentioned, like BMDC registered physician at the moment. So the findings of the study, I think you can see like we had predominantly female participants, 55.8% of the study participants were female. We had mostly young participants. So it seems like young doctors were more responsive to online surveys. So interestingly, the income grading, if you see, most of the doctors were like the young doctors, they had income level below 40,000 per month, which actually shows the poor wage the system of our country. Like the doctors are not earning that what we are thinking of. So interestingly, I think I will directly jump to the prevalence of anxiety and depression. You can see directly from here, like 23.34% of participants had mild anxiety symptoms, 39.9% of them had moderate anxiety symptoms, and 14.6%, which is extremely high, they had severe levels of anxiety. In case of depression, 25.5% have mild symptoms, 18.84% had moderate depression symptoms, and 4.6% had severe depression symptoms. I already mentioned like 16.8% of Bangladeshi populations have different forms of mental disorders, which is a pre-COVID statistic. So you can see like how drastically the situation has changed during the pandemic. So if you see the factors associated with anxiety and depression, so age, marital status or income, which were like not significantly associated with anxiety and depression, but gender, our female doctors were very, very responsive to develop anxiety symptoms and depression symptoms. So they were suffering more. And we had some very interesting question like, do you feel that you have been provided with enough training like any form of online or offline training related to COVID-19? So those who said no, they had more anxiety symptoms. We asked them, like, do you feel ready to deal with COVID-19 positive patients? So those who said no had more anxiety and depression symptoms. And interestingly, when we asked them about the fear of being infected by COVID, definitely most of the participants said yes, and they had more anxiety, depression. Those who were concerned about being infected, of their family members, they had more anxiety symptoms. We had a parallel study going on. The findings were already published in PLOS One lately. So it was related to willingness of our physicians to serve during the COVID-19 pandemic. So most of the doctors, they say they are willing to serve. So when we are being blamed, like doctors are not willing to support, so it's very interesting, like doctors are actually willing to support, but they were not feeling protected enough against the COVID-19 pandemic. And also they were very, very afraid of being infected. And also their family members' safety was a major concern. If I go a bit further, you can see like a couple of very, very distracting factors, like those who had COVID-like symptoms during the pandemic, not tested positive like fever or breathlessness, they had more anxiety symptoms. Those who had, interestingly, many people talked about incentive, but in our study, when we talked them about incentive, it had no value to the doctors. They wanted appreciation. They don't, look for incentive to have. They wanted to support just to have the appreciation there. the fighting they are doing at the time. Interestingly, PPE had a very major concern for them, personal protective equipment. So those who had adequate PPE at that time, they had less anxiety and depression symptoms. And those who had to buy PPE that time, like self-funded PPE, they had more anxiety and depression symptoms that time. Knowledge of COVID, when they are getting it from random YouTube or Facebook sources, they had more anxiety, they had more depression. When they are getting information from IDCR website or WHO website, they had less anxiety and depression symptoms. Interestingly, laser or such activities had no impact on their mental health status, but sleeping. Many people complained of severe sleeping disorders, severe sleeping problems during that time, and it was relevantly very much connected to their mental health status at that time. One of the factors which I personally felt very important, like some of the doctors talked about facing obstacles or humiliation while getting into or back from the work by regulatory forces. It happened. You can check the newspapers that time. Those who mention about this humiliation, I definitely should talk about, the landlord. Some landlord say like, no, doctors should not, get into my house. They have severe mental, trauma at that time, stress and anxiety, depression symptoms will have. Some interesting factor of what we tried to make it a very interesting, study, because we added some of the questions which are tricky. So we asked them do you think you are able to give your maximum concentration on your job after this pandemic? So those who say no, they had more anxiety and depression symptoms. It is very important in a sense, like they need support after the pandemic. We are still going through the pandemic, so the support time is coming up. And I think I need to go a bit faster. So I want to show you some the logistic regressions or the also binary logistic regressions. So the female the physicians, they were like 2.1 times higher than the male physicians to develop anxiety symptoms. And definitely the incentives you can see like that had not much impact what we have thought of. And interestingly, earning staff. So when we ask them, like, do you think you earn enough to support you and your family during the pandemic? Those who said no, they are like 2.2 times higher than the other those who would say that we are earning enough. And interestingly, most of the doctors, they said like the situation is creating a negative impact on my day-to-day life. And those who said so, they are like 2.3 times higher to develop anxiety symptoms and 2.7 times higher to develop depression symptoms during that time. As many of the doctors said, like it's hard to stay away from social media, to stay away from, we are constantly using it and we don't know how to control it. So problematic internet use might be another factors to explore in any of our next studies. Interestingly, one of the statements you can see from here, like how is human contact making you feel? Many doctors say like we are agitated, we are not feeling comfortable to deal like touch cases. So those who talked about agitation, they are 6 times higher to develop anxiety symptoms and depression symptoms. And, like this agitation are kind of very normal during any kind of pandemic, even if like SARS and COVID as well. So these are the snapshots of the findings. We had a couple of other findings as well. So I wanted to give you some interesting findings from that, and I definitely want to mention like we need further research and study. I explained now it's not without limitations. It was an online survey, so definitely face to face we have much more authentic information, but we had no option to go other than online, and we had very limited samples, so we cannot generalize it. But overall, it is very important to show like our doctors are human. They need support. They have fear for their family. They need to be protected. And the importance of institution and then state support for doctors is a public health approach, and that should be prioritized. Industrial of psychosocial interventions to non-specialized workers can be a foundation for mental health care systems addressing emergencies like this pandemic, what we are going through at the moment. We need coordination of this foundation. We need to involve more and more people so that they can be supported from the root, like a doctor from Tahiti, Sunamganj, or Rangamati, or Dinajpur. They need they deserve the same care a doctor of Dhaka Medical or Solimullah or Sorority is having. So definitely we need to be much more inclusive and adoption of digital platforms. That we know about telemedicine, but we need to be very much clear like how digital interventions can facilitate the delivery of intervention across the continuum of care. The doctors should be the center of this digital intervention so that they can receive support when they need it. So I think I'm done with my presentation, and thank you so very much for giving me this platform to talk about. Thank you so much. I'm open for question and answer now.
Okay, thank you, Dr. Tasdik, for a nice presentation. Sorry for the inconvenience for some technical glitch, but I think we are back to our session. Nice and good. So let's see whether we have any questions from. Let me check the Google form that we have here. Yeah, there are a few questions about Tasdik. First one is, why did you choose snowball sampling, and how did you do it? That's one thing. The next question is, your population was more than 18 years. How a registered physician be 19 and 20 years? Okay, that's a question you can answer. How 16% registered physician was 34 years or 24 years or less? This is very critical observation. Could you please respond?
Yes,
yeah.
Definitely, sir. The first thing is snowball sampling. I know snowball sampling, we mostly use it for sensitive topic like, sexual exposure, drug abuse. So we use this method for this particular study because at that time, getting a registered physician was a bit of complexity because I don't know, like 400, 500 physicians by myself. So we asked one doctor to share the link with another doctor. So it's kind of, we use this snowball method so that we can get a desired sample within a minimum time. So you can see, like I mentioned, convenience and snowball together. So we used convenience sample. We used 5 research volunteers who were used all the basic doctor-based platforms like platform itself, Bangladesh Doctors Federation, APS, whatever group we have, we used all those social media platforms, and at the same time, we requested our doctor friends to share this so that we can get desired sample over 3 weeks time. I know it's not the ideal method, but we had no other options at that moment to reach to the physician. So we acknowledge that in our limitations segment because it is under review. This paper is under review at BMJ Open at the moment. Okay, so our population was 18 plus. So no doctor were like 19 or 20 years, of course. So you correctly mentioned like 16% registered physician was 24 years. Like we included intern doctors as well because no, not intern doctors. So we included just past those who received the BMDC certification. We know that in Bangladesh, the passport and the age is a bit tricky. We always, deduct some years from our not the regular birth year. So if someone is born on 1988, they give like 1990 to, I don't know why, but that is the thing I think happened in our case as well, because we used the BMDC registration number and we had no options. Like if some doctor is saying I'm 24 years, we need to acknowledge that I cannot change it. So that is the reason, like you can see like 16% of our physicians. And I also want to mention Dr. Rashid because 5 of our research volunteers were young. They just passed from 5 medical colleges. So in many cases, I think they circulated the tool to their friends. I think that reflected on, having more youth perspective to this study, which I feel like not bad either, because youth voice is all we need to go further. So yeah, that is my response to 3 of your very important questions. Thank you so much.
Okay, thank you. I don't see any other question from audiences, but I have one issue to raise that when you calculate your sample size, you calculate it on the basis of 10% non-response. But while you are doing it, what was your response rate?
Oh, the response rate was 97.6%. That was I mentioned. So in most cases, like people agreed and they, it was a convenience method, our friends and, the people from our contact. And online, it took limited, but very short time, I think. We mentioned 25 minutes, but when we calculated the actual time, many people have completed the form within 18 minutes, 16 minutes. So that is the reason, like most of the participants, they actually completed the online form till to the end. So we had like a very good response rate. Yeah.
Yeah, thank you. This online research and questionnaires uh, administration is becoming very popular here. We must learn out of it. And
Yes,
how to
sir, I want to mention one thing, like we follow the Cherries guideline, which is absolutely dedicated. The guideline is, developed to use online surveys. So it is kind of, a different experience from for us as well to see how this online form is working. So it is the first study we conducted with this method, and then we used this method, and we have we already published like 15 papers from COVID investigation. So one of the studies we got like more than 3,000 responses. So eventually it's getting popular, and eventually people are getting into it like, okay, online method is kind of generating more insights and evidence. So we should participate to this service.
Thank you. I think for the sake of time, we move to the next presentation.
Thank you, sir.
So our next presenter is Lieutenant Colonel Dr. S.M. Nurul Irfan. He's a Fleet Medical Officer of Bangladesh Navy, and he will be talking on predictors of psychological impact among the healthcare workers exposed to COVID-19 cases in Combined Military Hospital, Dhaka. Dr. Nurul Irfan, please start your presentation.
Thank you very much, sir, for giving me the opportunity to talk something about my article, my research work, which I did during the peak season of COVID-19 the last year. That happens in the Combined Military Hospital, Dhaka. My title of the topics was the predictors of psychological impact among the healthcare workers exposed to COVID-19 cases in a tertiary hospital of Bangladesh. I am Dr. S.M. Nurul Irfan. At the same time, I am one of the student officer of MPhil Preventive and Social Medical Medicine, doing in Armed Forces Medical Institute. That's all from about myself, sir. Sir, all of us know that since December 2019, the world is experiencing the unprecedented global pandemic of novel coronavirus disease 2019, which is caused by the SARS-CoV-2 virus. By now, the global outbreak of coronavirus has reached a total of over, sorry, these statistics during the manuscript writing time I to mention here. And worldwide, near about 25 lakhs deaths at that time. As a consequence of global pandemic, the novel coronavirus was confirmed to have spread to Bangladesh in March 2020, as all of us know. And by now, the number of affected people has been increasing, with total number of near about 8,000 plus death cases. And as part of the total community, member of Bangladesh Armed Forces also suffers from this disease. On 6th April 2020, Bangladesh Armed Forces revealed its first case of COVID-19 case, and so far around 12,700 affected individuals treated in Combined Military Hospital, Dhaka. So with rapid spread of the COVID-19 infection prevention, identification and management of cases, as well as ensuring effective strategies to protect public health, has become a critical challenge for the global health system. These challenges, although primarily emerging from an infectious disease with physical health implications, may also affect mental health and well-being profoundly, which may have multiple impact on mental health across population, which necessitates the attention of global health researchers and practitioners. Healthcare workers generally are at risk of exposure to highly infectious pathogens while they care for patients, or by exposure to patients' environment or biological samples, which may worry them of being infected as well as transmitting the infection to others. As a consequence of increasing COVID-19 cases, many of the healthcare workers are working beyond their regular schedules to meet the increased demand of critical care, which makes these healthcare workers susceptible to anxiety, depression, stress, and insomnia as well. Healthcare workers are particularly vulnerable to many job-related hazards and undergo a considerable amount of emotional pressures in relation to their jobs. With that, sir, my methodology, my objective was to assess the predictors of psychological impact of COVID-19 in terms of depression, anxiety, and stress among the healthcare workers in Combined Military Hospital, Dhaka. And it was a descriptive cross-sectional study and conducted from 1st July to 30th September 2020 at Combined Military Hospital, Dhaka. The healthcare workers, mainly doctors, nurses, and medical paramedics, were the study population, and I adopted purposive sampling. As sample size calculation, I took total 319 healthcare workers, and I used a semi-structured questionnaire with the psychological impact are measured by the DAS-21 scale, depression, anxiety, and stress scale 21. The data processing and analysis were done using statistical package for social science in version 23. Frequency, percentage, mean, and standard deviation were used for descriptive statistics, and binary logistic regression analysis was performed to estimate the strength of association, which are demonstrated by the odds ratio. The two tails p less than 0.05 was considered statistically significant. These are the scoring guideline for the depression, anxiety, and stress according to DAS-21 scale. As per the scale, 0 to 9 for depression was considered normal, 0 to 7 score was anxiety for normal, and 0 to 14 for normal individual. Basing on this, as per this slide, the categorization for the depression, anxiety, and stress were done. Now, as far as results sections are, around half of the respondents belongs to this group less than 30, because at the same time 65.6% were male, and highest 41% were HSC qualified. And majority of them are Muslim, and 70% respondent belongs to the nuclear family, and 41 are state and family. Here I am sharing the odds ratio as well. As far as odds ratio is concerned, only for the depression, being graduate and performing overtime duty, these two I found the risk factor for the depression among the healthcare workers. And married respondents, in contrast to the unmarried respondents, were found protective for the development of depressive symptom among the healthcare workers. At the same time, as far as anxiety and stress is concerned, being HSC qualified and graduate, all are statistically significant, odds ratio more than 1, and residing in the family accommodation is found very much risk factor for the development of anxiety. At the same time, smoking habit give one of the risk factor for the anxiety among the healthcare workers. At the same, similarly, length of service, attending about 41 to 80 patients per day and performing overtime duty, all are become the risk factor for the anxiety. At the same time, I found doctors and nurses are the protected for developing anxiety during my study, and staying in the nuclear family and serving in the current place of posting for less than 20 months were protective factor for development of anxiety. As far as stress is concerned, graduates develop the stress more than the other educational qualified healthcare workers, and reside in the Shoinik line, and that is one of the place where the usually medical paramedics used to reside. They are found that their more risk factor for the stress. And performing duty at the emergency and casualty department found more risk factor for the stress, and performing overtime duty as well found the risk factor for stress. As I already mentioned, the medical paramedics are the major share among the respondents, is 42.1%, which is followed by nurse, and 19.7% were the physicians. Here I want to mention about the occupational characteristics. As I already mentioned, the medical paramedics are the main respondents, followed by the nurse and the physicians. More than half, the 54% the length of service less than 10 years, and their average length of service were near about 11.67 years. The highest 38 respondents attended less than 40 COVID patients daily. 52% respondent did their daily duty at corona ward, and 51% performed duty more than less than 9 hours in a day. 53% responded perform overtime duty, and which I found that overtime duty did personnel developed both depression, anxiety, and stress as well. And one of my question was what motivate them to perform to treat the or to attend the COVID-19 patient, and I found that professionally motivated individuals are the major person who mentioned that they're professionally motivated. The other option were the humanitarian motivation or job related motivation, etc. And as far as anxiety, depression, and stress is concerned, I found 21.6% being depressed, from mild to extremely severe. 43% were anxious, and 24% were depressed, stressed. These are the distribution of the respondent basing on their depression, anxiety, and stress cutoff values. Results of binary. So in conclusion, the psychological problem among the healthcare workers should be focused in any public health emergency. That's because they are very much under psychological and physical pressure in managing COVID-19 patients. In our study, we investigated the psychological impact among the healthcare workers who were engaged actively in the management of COVID-19 infections, and analyze the influencing factors which can guide us to develop psychological intervention programs for the healthcare worker that are tailored to address the different psychological symptoms and need of the healthcare worker. And my recommendation, basing on my study findings, identification of highly vulnerable healthcare workers and connect them to required care as early as possible. Promotion of mental health service and resources with timely access should be available with an aim to positive mental health outcomes and psychological resilience across the healthcare workers. Limiting or banning mandatory overtime duty, initiation of integrated stress management program, healthcare worker assistance program, and disease management program by health promotion activities. Routine monitoring, evaluation, and surveillance of mental health among the healthcare workers. Provision of timely adequate logistics like PPE, gloves, masks, and other essentials to the healthcare workers. Inception of social support system for the healthcare workers. Support from administrative authority can motivate the healthcare workers in dealing with the psychological aspects, and good working environment should be ensured, which will give mental support to the healthcare workers. And I profoundly acknowledge the support and sharing resource of Professor Dr. Ziaul Islam, Head of the Department of Community Medicine, NIPSAM, Brigadier Taufiqul Hassan Siddiqui, Colonel Dr. Mahbub Rahman Bhuiya, Lieutenant Colonel Shamita Mithun, and Dr. Sheikh Mohammad Abu Hind Mustafa Alim, who is the main author who validated the DAS 21 score in Bangla, and participant of the study, and matron and other words in charge of the CMS Dhaka. That's all from my side, sir. If I have any questions, sir.
for your presentation. Very good and very descriptive. And let me see whether we have any question. In chat box, I can see that there one question for you. Was there any assessment tool to identify the predictors? And did you find any relation between religion and predictors? This is one question. Yeah, there are a couple of questions for you. One is, how will you explain that the depression increases with education? The next question was there any assessment tool to identify the predictors? And did you find any relation between religion and predictors? These are the two questions.
Yes, I got the question, sir. Actually, assessment tool predictor, I use the DAS 21 scale, and my main I want to find out the predictors based on the socio-demographic and occupational aspects of the healthcare workers. And based on my findings of the logistic regression, I found that these are the risk factor or predictive factor for the development of depression, anxiety, and stress. And I found religion was not any. I found religion not any significant association or significant predictors for the development of depression, anxiety, or stress. At the same time, other than Islam, only other religious believers really, as it is a as it is a military organization. Other than Muslim, the respondents were very less in my study. At the same time, the next question. Psychological support intervention. I already mentioned the social support system, the support from the administrative authority, regular monitoring, surveillance. These sorts of support intervention system, I think is more important. And another question, sir.
Yeah, I think these are all. I think there are no more additional questions for you.
So another question, sir, depression, why it is more than in graduate?
Oh, yes.
Yes, sir. In my opinion, sir, the more educated person who are exposed to the consequences of the COVID-19 cases, I think they become, because at the initial days there were a lot of social stigma, lot of uncertainty, lot of human cry, lot of humor that may affect the educated person like graduates more than the, in my opinion, sir, than the other group, sir.
Okay. So if I'm not wrong, in your presentation, that compared to doctors, others have lower rate of depression and anxiety. Doctors have the higher rate of anxiety, depression. Is it correct?
Yes, sir.
Why it is so? Why doctors have high? Because other healthcare professionals are more close to patient and they deal with patients. They stay longer time with patients.
Opinion, I think, sir, that the education maybe they know their by virtue of their education or by virtue of their position in the ward or position in the society, they might expose to the more concerned patient than the others.
Yeah, probably they know more about the consequence. Yeah.
Yes, sir.
Thank you very much. Very nice presentation, informative one. So we move to the next presentation. So our next presenter is Dr. Ahmed Khairul Abrar. He is a research medical officer of the Department of Epidemiology and Research of National Heart Foundation Hospital and Research Institute. And he will be talking on a quit attempt among the tobacco smokers during COVID-19 pandemic in Bangladesh, a rapid survey. Dr. Abrar, please.
Thank you. Good afternoon and welcome to the session. Dr. Abrar is here from the Foundation of on which attempt on the tobacco smokers during COVID-19 pandemic in Bangladesh. It is my great honor to present in the first Bangladesh Congress on Epidemiology and Public Health. Bangladesh is confronting a severe public health crisis for the last 1 year, along with the rest of the world. Already more than 9,000 people died and more than 600,000 have been infected by this novel SARS coronavirus 2. Third contagious coronavirus after MERS and SARS. This coronavirus attacks multiple organ systems, but lung is the primary target organ and respiratory system is the mostly damaged in COVID-19 infection. Tobacco smoking alters human natural immune system, especially the lung immunity. Smokers have a lower lung immunity and thus are most susceptible for respiratory infection and inflammation. In different studies, it was found that smokers at higher risk of getting critically ill if they got infected by the novel coronavirus. After thorough review of studies, World Health Organization concluded as smokers are more likely to develop severe disease with COVID-19 compared to non-smokers, and thus they recommended users to take immediate step to smoking. In study conducted in United States last year, it COVID-19, about 23% tobacco smokers attempted to quit during current pandemic. In Bangladesh, there are more than 19 millions of adult smokers and another 40 millions are victims of second-hand smoking, according to the Global Adult Tobacco Survey 2006. Wide in that context, object the change in amount of smoking quitting attempt in smoking. In social media based cross-sectional on the adult Bangladeshi smokers during the early long structured questionnaire made on Google Form forest rate was 20%. Rounds. Eight of the two-thirds 32%. Majority of the participants had a about high risk of smokers during COVID pandemic. A significant number of respondents, 39% almost, had different thoughts. Regarding smoking habit of the participants, half of the respondents continued their habit of smoking at home during the pandemic. Some of them started it during lockdown period, but we found that 14% of smokers stopped smoking at home after corona outbreak. About two-thirds of the respondents claimed to reduce their amount of smoking during the pandemic, in a significant amount. And at that time, according to their claim, majority of them used to smoke up to 5 cigarettes per day. We found that important causes of smoking habit change as lack of sufficient opportunity to smoke due to lockdown, fear of getting affected by COVID-19, financial constraints, and the holy month of Ramadan. Incidentally, our data collection period was the month of Ramadan, so we included this variable also. By logistic regression modeling, we found that not smoking at home, fear of getting infected by COVID, and financial constraints were the factors significantly associated with reduction in amount of smoking. In our study, about 22% respondents claimed to attempt to quit during the period of COVID-19 pandemic to stay safe. Here, a point to be mentioned that we had defined quitting attempt as refraining from smoking for at least 24 hours. Attempt to quit was significantly associated with the habit of not smoking at home and conception about risk of smokers during COVID outbreak. They were about 3 times more likely to have an attempt to quit smoking who do not smoke at home and have a perception about higher risk of smokers to get critically ill by COVID-19 infection. In conclusion, as COVID-19 has no effective treatment yet, smoking cessation is a significant preventive measure to stay safe on pandemic. During this outbreak, about two-thirds smokers of this study reduced smoking in notable amount, and about 22% smokers attempted to quit in fear of pandemic. Quitting and reduction in smoking was significantly associated with habit of not smoking at home, conception about risk of smoking during COVID outbreak, and financial constraints. From these findings, we can suggest to ensure smoke-free home and strict implementation of existing tobacco control law regarding smoke-free public places to reduce burden of tobacco consumptions in Bangladesh, as well as to control the current COVID pandemic. That's all from my part. At the end, I would like to acknowledge my supervisor, Professor Sajjad Choudhury, and my colleagues and who were the part of this study. Thanks for patience hearing. Thank you.
Okay, thank you, Dr. Abra, for your nice presentation. Is there any question from the audience or listener? Let me check. So one question is from, what was the case definition of smokers?
Actually, we have asked at the initial stage of questionnaire, one screening question that are you a smoker? And we defined smoking as the who used to smoke at least one stick per day for the last 1 month.
Okay. Then another question was what, I think he's still writing. So the question is, what was, let him finish the question first. Dr. Abra, can you see the
Yes,
question?
sir. I'm seeing a question from Dr. Tasdiq Deep. He asked about, he was concerned about the non-response rate. Our response rate was 20%, and he's thinking it is more prone to non-response bias. Yes, actually, for this kind of open platform questionnaire, 20% is not so bad, although for generalizability, it is not so supportive. We found in different online studies regarding this kind of open invitation, around 15 to 35% was the response rates.
Okay. So in Google form, there are a few questions. Can you see the Google form?
No, sir.
Okay, then I'll just read that question. One, you have already answered about the case definition of smokers. The next was, what was the confounding variable you present in this study, and how did you remove or minimize it? Okay, what was the confounding variables you regard present in this study, and how
Actually,
did you remove or
yes, sir.
minimize it?
For quitting attempt and reduction in smoking amount, we thought the presence of holy month of Ramadan is the main confounder factor, and we made multiple logistic models to control the confounding factors.
Okay. Another one I just posted it in on chat box. That is 61.5% had more risk with COVID-19 with the same color in wider more. Is it showing any color in pie chart?
Probably not. Probably that was my mistake.
Okay. Okay, then for the sake of time, I think we should move to the next presenter. And unfortunately, Dr. Nauroz Afrin, who is a graduate of FETP program and currently attached in NIO, is not is unwell today. It will be unable to present. So we move to the last presenter, Dr. Mohammad Habibullah Talukdar, the associate professor and cancer epidemiologist and very renowned cancer advocate in Bangladesh. He will be presenting about a review on the existing cancer screening program in Bangladesh and the way forward. Dr. Talukdar, please.
Thank you. Thank you very much. Thank you, dear moderator, Professor Chaudhary, and our other presenters and organizers. I like to present my slides from here. Is it possible?
Yes, you can share your slide from your.
Okay, I can try. Is it okay? Is it visible?
Yes, yes, you can see that.
Okay. Thank you again. I like to present on a review on existing cancer screening program in Bangladesh and the way forward. I am Dr. Mohammad Habibullah Talukdar. Actually, this one is not a deep or a very serious, review. This is a superficial. Especially, I like to mention the modality or the approach of the cancer screening, which is not, which is, I think this is not the way. So what is the situation? At first, I have to quote from an consultation meeting of International Cancer Screening Network of India. This was published in Lancet. You can see the link. Screening at the population level, when planned and organized, can greatly benefit the population, whilst disorganized screening can increase cost and reduce benefits. An organized screening program provides screening to an identifiable target population and use multidisciplinary delivery teams, coordinated clinical oversight committees, and regular review by a multidisciplinary evaluation board to maximize benefit to the target population. Now, we can look at our current situation, country situation. National Cancer Control Council we have, but this is non-functional for last 10 years at least. National Strategy and Plan of Action for Cancer Control 2009 to 2040 was approved by the ministry, but not updated, and programs and activities not taken in line with this document. No National Cancer Registry Program, hospital-based cancer registry functioning at NICRH, progress not satisfactory. Population-based cancer registry is lacking, no data of our own dependent on Globocan data, no coordinated concerted effort within the public sector. You know, there are many program under sector program working on cancer, but there is no concerted, no communication, no coordination. Very recently, a coordination committee has been formed just last month. Voluntary organizations not involved effectively with ongoing activities. About cancer screening, establishment of National Center for Cervical and Breast Cancer Screening and Training Program at BSMMU, 480 VIA and CBE center established in different level of public hospitals. About 50% of Ubudila hospital has been covered. Total VIA tests done in this 15-year since this starting of this project, that is 2.5 million we can say, about 26 lakh. 25 colposcopic clinics have been established and 280 trained colposcopists. National Strategy for Cervical Cancer Prevention and Control 2017 to 2022 developed as a vertical program. Plan to implement and scale up population-based cervical cancer screening within code plan, but not implemented. Visualization with acetic acid VIA is the method for mass level of screening in our current strategy. Naked eye inspection of cervix after applying 3.5 to 5% acetic acid using a good light source, outpatient procedure, safe, rapid, reliable, and inexpensive, and anesthesia not required. These are the facilities for VIA. And the first program was taken in 2005. There was a pilot program that was based on cervical cancer. Eventually, breast cancer was added as clinical breast examination. Now, the performance till June 2018, from 2005, the target population was estimated 25 million that time. Thousands of women, and total VIA test done. 18 lakhs 16,800, and positive test was 85,000, and 4.68% of positivity. We can move to next slide. Now we will compare with the standard procedure as per guideline of IARC, you know, International Agency for Research on Cancer. This is the sister organization of WHO to take care of the cancer research, cancer registry, and other activities worldwide. Concept of cancer screening. Cancer screening is the asymptomatic cancer screening done on asymptomatic apparently healthy people, high risk people. Simple non-invasive tests should be done. That should be inexpensive and randomly applied on high risk group of people or target population. Now, aims of cancer screening is to prevent death from invasive cancer, improve quality of life, treat early preclinical asymptomatic cancers, treat preclinical precancerous lesions, and there are two types of cancer screening. One is organized, and another is opportunistic, unorganized, or spontaneous. The criteria of organized screening program is basically a systematic call of the identified target population, systematic call with motivation, and those who will not respond in time, the recall system for those, and follow-up of a well-defined target population. It's not a survey. Cancer screening, population-based cancer screening is not one-time effort. So follow-up of a well-defined target population is a must. Information linkage with information system with linkages to cancer registries or death registries where present. Now, what are the indicators to measure effectiveness of a screening program? Before that, I like to mention that there should be three suitable disease, suitable test, and suitable program. And what are the indicators to measure the effectiveness of screening program? The number of people screened, the proportion of the target population screened, the number of times screened, the number of screen positive people, the number of screen positive people undergoing diagnostic investigations and treatment, and the number of people diagnosed with preclinical disease. Positive predictive value of this screening test, the total cost of the program, the cost per positive case found, and suitable disease, suitable test I have already mentioned. There are criteria of some of screening test: validity, reliability, sensitivity, specificity, positive predictive value, negative predictive value, and from public point of view, simple, non-invasive, affordable cost. For breast cancer, there are three methods worldwide used. Mammography is the first choice, then clinical breast examination and breast self-examination. But mammogram is not encouraged below the age of 50 years. This is the mammogram machine and mammography finding. For cervical cancer, I have already mentioned that VIA is the method we are practicing in our national program. Incomplete, weakness of ongoing program. I have already mentioned the criteria and indicators of a successful screening program. If we evaluate our ongoing program, the weakness of ongoing program is incomplete, because as per WHO recommendation, at least 3 cancers of breast, cervix, and oral cancers are feasible, even in a low resource country. We have no oral cancer screening program. We have only program on cervical cancer and breast cancer, and unorganized and opportunistic, I have already mentioned, and very poor coverage, 5 to 6% in 50 years. Lack of mass awareness with motivational activity among the catchment population. We have established VIA centers, but we did not take any program to educate the people, for awareness of the people, and motivational program for the women to have this facility. And lack of involvement of important government institution, including NICRH, medical college, in implementation. This program is running basically by BSMMO, Gynae department. As it is a national program, it must be under the line director of NCDC, and all other program under a sector program should be coordinated. And National Cancer Institute is not part of this. The medical colleges are not involved. Highly centralized, all the program training of the whole country is based on only one center that is situated in BSMMO. Lack of involvement of epidemiologists, preventive oncologists, public health professionals, voluntary organization. Look, cancer screening is a public health program. It must be multidisciplinary. The first slide I have shown, there is a multidisciplinary approach should be there. Lack of proper referral support. For cervical cancer, there is some sort of referral system. The VIA positive cases are referred to the nearest colposcopy center, and finally to medical college hospitals or NICRH. But for breast cancer, they are doing clinical breast examination, but there is no referral system has been developed. Okay, I am
Sorry to intervene. We have to finish it by 4 minutes.
okay. I think it will be completed in time. Strength and achievements. A running program of about 15 years. This experience and the infrastructure we have developed. This is our strength. Equipment, trained manpower. These are also our strength. Already screened about 250,000. Sorry, the figure is there is a mistake. It will be 2.5 million 25 lakhs. 10 has been omitted. An excellent primary healthcare system. We always mention that our primary healthcare system is an excellent, so we can use this primary healthcare system. And recent updates, I should mention that establishment of 8 divisional full-fledged cancer centers. This is under implementation. Already ECNIC has approved a project of to establish 8 medical college hospital, 8 15-story building, where 8 story for cancer center, 100 in bed, 100 bed for inpatient, 50 bed for daycare system, 3 most equipped, most developed radiotherapy machine, and 6 departments, including cancer epidemiology, full-fledged department, gynae oncology, surgical oncology, pediatric oncology, and radiation oncology, and medical oncology. So this is a very, very good progress. Provision of full-fledged cancer epidemiology department, I have already mentioned. Mobile cancer awareness and screening units have been taken there. These centers will be utilized as regional hubs for all cancer control activities, including awareness, screening, and training. The present highly centralized activities will be decentralized when these centers will be developed. A new hope, new initiative. Finally, it was our long demand that the government should approve a population-based cancer registry, at least piloting in Ubojela. Dr. Suel is well informed about this. And finally, during this midterm review of the current sector program, the government finally has approved piloting of population-based cancer registry integrated with screening for breast, cervix, and oral cancers in 2 Ubojela. We are preparing the concept paper now. For COVID situation, it may be delayed, but it will be started under NCDC program. Okay, and now way forward. Utilizing achievements and newer developments, redesigning of the screening program. It must be evaluated and redesigned from facility-based bias centers to community-based cancer screening program. And National Cancer Screening Program under the umbrella of National Cancer Control Program under NCDC DGHS. I strongly recommend that no vertical program. This is from maternal and child health part of the DGHS program, but it should be under the NCDC, and all other programs and departments will have to be in an umbrella, under an umbrella. Oral cancer screening to be included as per WHO recommendation. Piloting of organized community-based integrated cancer screening program to be undertaken already has been approved. Utilizing and preventive oncology services and departments to be established at NICRH and other tertiary level of facilities. Concerted effort involving DGHS, NCDC, maternal child health program, involvement of voluntary organization, professional bodies and NGOs under central monitoring and supervision with specified TOR, active involvement of mass media. These are my recommendation for way forward, and we must redesign the existing cancer screening program. So thank you very much, and I acknowledge Professor Sabina Khatun and Professor Ashraful Nisa for some slides. Okay, thank you very much.
Thank you, Dr. Habibullah, for speaking from basing on your vast experience on cancer epidemiology and cancer prevention in Bangladesh. I know we have been working with him for a long time for NCD control and prevention, and he was actually very much strong. He played a very strong role in establishing cancer epidemiology department in newly that is cancer hospitals that are going to be established in 8 divisions. So we have a good opportunity for cancer epidemiologists there. So he played a vital role in introducing these departments there. So I don't think we have much time for discussion, but probably a quick question from you, from audience was there. One question, I think you already answered about it. Is there any policy in process to have a population-based data collection method or to build a database system regarding cancer or cancer screening? I think you have already discussed in your presentation.
There is a system, for tracking cancer data from the existing DIS2, but I don't think that it will be a good good outcome for cancer cases. There should be separate database in MIS, within MIS of DGHS, and a cancer cell should be identified for this cancer database, and cancer epidemiology department will have to be access to this database for analysis and interpretation and reporting on these data. And I have already discussed with the Dr. Ashrafi and others at MIS, and also line director in NCT, Dr. Rubed Amin, and they are very much positive. We must redesign the program, including the database. Okay, thank you.
Okay, thank you. For the sake of time, I think we actually finished the discussion here, and I think we had a very nice session this afternoon, focusing on in-city epidemiology. Basically, we actually discussed, presented 4 papers looking after the mental condition on physicians and healthcare workers on of this pandemic, like COVID. And also we have heard about the impact of COVID on tobacco use behavior. And lastly, we have a very, I would say, very directional review from Dr. Habibullah Talukdar. And one thing came out is that we are becoming very much familiar with doing surveys based on online or social media. And 2 papers are presented here that based on social media survey. I think we can exchange views among our researchers how to make best utilization or how to refine the process of social media survey. I think in the future it will become one of the very important for our epidemiologists. And the knowledge that we gained during COVID period for utilization of social media will also help us in future to gather information for diseases and morbidities also. And with all these words and thanking all the presenter, I'd like to finish this session, and over to Dr. Omar Kaim.
Thank you so much, Professor Sohel Reza Chaudhary, sir, and all of the respected presenters. From organizing committee, I will acknowledge all of your contribution to the public health, and sorry for inconvenience in the technical issues. Thank you all.
Thank you.